put this on. I very much appreciate you all sticking around. And Dylan will pull up those slides. And we'll go through a couple of cases. I have 3 hypertension cases, and I have some interspersed slides just to back up some of the points. I have added, last night at about 12:30, I added a couple of slides, and I'm going to repost this on the web because it goes into a little more detail on ABPM. But you'll follow along with me. One slide is just 2 slides later, and some other ones are new if you're following on your tablet.
They should be updated on the tablet now.
Oh, they're updated on the tablet now. Oh, thank you. Wow. Okay, so I have a last 4th case on heart failure, and we might get to it, but I really wanted to concentrate on the hypertension because I went through the cases when I talked about heart failure yesterday. Okay, so case 1, 52-year-old black male recently relocated to your area and is in clinic to establish care for his hypertension. He has a history of hypertension for the past 10 years, been managed by his lifestyle modification alone. Over the years, he's been able to lose weight, exercise, cut down on his alcohol to 1 beer per day, and eats a low-salt, high-potassium diet. He checks his blood pressures out of the office, taking his blood pressure properly, because he shows you how he does it in the office, and when he does, blood pressures are running about 132/82. His family history, his mother had hypertension, which was well controlled on medications until she died at age 89. He's not aware of his father's family history. He has 2 SIBs alive and well without hypertension. Office blood pressure today is 134/78, an average of 3 readings taking 1 minute apart using an Omron oscillometric device appropriately taken, so an AOBP. His medicines are enteric-coated aspirin, 81 milligrams a day. He's on atorvastatin, 10 milligrams, and he's on no blood pressure medications. On physical examination, his BMI is 29. His waist circumference is 37 inches. His resting pulse is 76 beats per minute. His eye grounds are without hemorrhages or exudates, and no arterial or narrowing is noted. Cardiac exam and peripheral arterial exam are normal, and on a lower extremity exam, he has no edema. His CBC is normal. His fasting sugar was 86, creatinine 0.8, total cholesterol 160, HDL 48, LDL 80. His sodium is 137, K is 4.2, his A1C is 4.8. His urinalysis is no protein and it's normal. Normal specific gravity, calcium is 9.1, TSH is normal, and his EKG shows normal sinus rhythm. Which of the following tests would you order in this patient? 1, an echocardiogram, and I can get to the posted answers. An echocardiogram to rule out LVH, a coronary calcium score, a urinary albumin to creatinine ratio, a serum uric acid, or E, no additional tests. Okay, and we have 8 people answering. We're going up a little bit. That's nice. Okay, and we're on the web. Now, can the web get in on this too? Yes. Oh, very nice. Okay, so we had 12 respondents, and the most common answer is no additional tests. And if we go to what I post, I agree, no additional tests. Now, if you, we can go over why. I understand why someone might want to get a urinary albumin-creatinine ratio. We do suggest that in diabetics, but clearly, if you look at the updated guideline that we went over yesterday, the optional testings are for an echo. It is much more sensitive than an EKG, but on the EKG, we saw no LVH. I don't really think that the cost of the echo is going to move you to do something differently right now in terms of what your strategy might be for this patient's care and what you might offer him for therapy. The uric acid, yes, asymptomatic hyperuricemia seems to be a target for risk, including cardiovascular risk, but we have no evidence that we should be treating it, and so we didn't recommend it in the guideline, and we did not recommend it was optional, a urinary albumin to creatinine ratio. But all the other tests I told you the results for. His estimated GFR was quite normal, and his urinalysis was normal. Yes, there was no protein in the urine, and he could have microalbuminuria, but in this particular case, we really have no evidence that treating the microalbuminuria with drug therapy would improve his outcome. So that's another reason why it's not recommended. Now, in this particular case, 52-year-old gentleman, what is the patient's risk over the next 10 years of developing atherosclerotic cardiovascular disease? Remember, the risk calculator is very important in patients such as this one presenting to me. So what is the patient's risk calculation? Is it 3.7%? Is it 7%? Is it 12%? Is it 16%? Or, can you move that slide up, Dylan? Or do we not need to calculate this to determine how to treat this patient? And let's see what people answer here. Is anyone using the risk calculator right in front of you? Very good. Okay. So that's interesting because it looks like I'm getting a different response than you all got when I used the risk calculator. Interesting. Because when I did it, I got, and this is from the 10-year risk, right? And the target is 10%, not 7.5% like in the lipid guideline, because in clinical trials in hypertension, most of the data suggested at least a 10% or more risk, not 7.5% used for the lipids. In this particular 52-year-old without cardiovascular disease, CKD, or diabetes, we want to use the risk calculator to stratify best therapy. Now, when I use the risk calculator, and granted, I do not have a good picture of what the risk calculator looks like on your app or on your computer, but it's similar to this. And when I did it, I got a risk of 3.7%. Of interest, notice he's on atorvastatin, and with a 3.7% 10-year risk, one of the questions would be, why is he on atorvastatin? If you look at the risk calculator, you have to put in, or you could put in, that he is on the statin, and it would come back and tell you perhaps he's not a candidate for the atorvastatin. So I predicted that his risk was 3.7%, which is less than 10%. But even those of you that pick 7%, you would have gotten less than 10%. In addition, you can do the lifetime risk of the patient. And this can be very, very helpful for convincing the patient that over their lifetime, their risk of developing atherosclerotic cardiovascular disease may appear to be greater than their 10-year risk at age 52. And if you do his lifetime risk on the calculator, I believe it's 36%. So if you're going to utilize lifestyle modification in this patient, I think that 36%, 1 out of 3 over their lifetime, with your particular presentation, will develop atherosclerotic cardiovascular disease, is a little more convincing than to tell him that over the next 10 years, 1 in 33 will, or 1 in 30 will. A question I wanted to, yes?
Are you considering lifestyle modifications treatment for high blood pressure in that calculator, in the calculation?
The calculation,
You answered yes, I was wondering.
the answer is no. We're not, we have no way of putting in that data of what of the important lifestyle modifications is he already making.
That might be the difference between our answer and your answer.
Oh, okay. Very good. Okay. Very good. So I wanted to pose this to you. I told you he's on enteric-coated aspirin. And I want to ask you, should this patient be on enteric-coated aspirin? Yes, no, or you're not sure. So I want to go over this. Okay. And so more people are, okay, now it's going a little more to no, or you're not sure. Okay. Well, let's move on. So more people felt no. And I just want to review this for you very quickly. And this is in your handout. This is United States Public Service Task Force recommendations for aspirin use to prevent cardiovascular disease and colorectal cancer. And the greatest evidence, grade B, is for adults 50 to 59 years of age with a 10-year predicted risk of cardiovascular disease. This patient's risk is less than that. So they recommend, as a grade B recommendation, initiating low-dose aspirin for the primary prevention of cardiovascular disease and colorectal cancer in adults 50 to 59 years of age, as our patient, with a 10-year risk of CVD or greater, 10-year CVD risk, not our patient's risk, are not at increased risk for bleeding. We haven't asked our patient that, but there's no evidence for that, and there was no evidence for bleeding. And they have a life expectancy of at least 10 years, certainly, and are willing to take low-dose aspirin for at least 10 years. It's a grade C if you're older, okay, and then it's insufficient evidence for either younger than 50 or older than 70. And so I just wanted to present that to you. The other question that could be posed to the patient, although many of us could argue that statins should be in the water of our cities for reducing risk, if you want to utilize the lipid calculator, the patient might not be a candidate for the atorvastatin either at the present time. Although there is one clinical trial, and he doesn't have multiple risk factors, but in the ASCOT statin versus placebo arm of the blood pressure, there was a lipid arm as well, and if they had 3 risk factors or more, the use of atorvastatin at 10 milligrams was more effective at reducing event rates than placebo. But he's not a high-risk patient with multiple risk factors. He just seems to have hypertension. Based on the patient's risk for ASCVD and stage 1 hypertension, how would you treat his blood pressure? And the answers are lifestyle modification with follow-up 3 to 6 months, lifestyle modification, follow-up in 1 month, lifestyle modification and antihypertensive therapy, follow-up in 3 to 6 months, antihypertensive therapy, when you see him, follow-up in 1 month, or none of the above. Okay, and the most frequent answer is A, lifestyle with follow-up in 3 to 6 months. And that is what I thought was the best answer. Now, when you want to look at antihypertensive drug therapy, the candidates would be stage 1 hypertension with established CAD, CKD, or diabetes, or stage 1 hypertension and a 10-year risk of 10% or greater, not our patient, or stage 2 hypertension, regardless of risk, because they're felt to be at high risk. And in those patients, you don't have to use the risk calculator. And here, you would always treat with lifestyle modification, but in addition, in those 3 categories, you would use antihypertensive therapy. So I showed you this, I think, yesterday, but I just want to go over it and just reinforce a couple of important points. So on the far left is normal blood pressure, less than 120 over less than 80, and it has a 2A recommendation for follow-up in 1 year. Then you have elevated blood pressure, 120 to 129, diastolic, less than 80, and here it's non-pharmacologic therapy and follow-up in 3 to 6 months. But our patient has stage 1 hypertension. So you should use the risk calculator calculate if it's less than 10% or 10% or greater. And in our patient falls into here, non-pharmacologic therapy, class 1. If they were 10% or more risk, it would be non-pharmacologic therapy and blood pressure lowering, antihypertensive therapy. And stage 2, non-pharmacologic and antihypertensive therapy. These are all class 1 recommendations. So at the minimum, if they're normotensive, we follow all adults up in 1 year, making sure they get their blood pressure. Now, this follows the patient with less than 10% risk with stage 1 hypertension. And here, like you answered, you're going to use lifestyle modification and follow up in 3 to 6 months. This is when the risk predictor was 10% or more. And here you're going to use lifestyle and antihypertensive therapy and reassess them in 1 month. Whenever you use antihypertensive therapy, until they're controlled, you follow them up, according to the guideline, in 1 month. Now, that's a lot of visits. However, it doesn't say that you have to see them face to face. And I know there are payment issues here. So whatever you think is best for your practice and how you manage your panel of patients is what you should decide in this situation. If the blood pressure goal is not met, you optimize therapy, you increase dose, and somehow you're in contact with the patient within 1 month, according to the guideline. However, once you meet the goal, then you follow them up in 3 to 6 months. And I wanted to present, I hadn't presented this to you. So this just follows up on the follow-up and when you use antihypertensive drug therapy versus lifestyle modification alone. Now, this summarizes what you use, the follow-up, okay, based on the patient profile. And this is something that I've put together for you. And you can see that the target is always less than 130 over less than 80. And it defines if you're going to use lifestyle alone or if you're going to use lifestyle and drug therapy. Questions so far? Comments? Concerns? This is a guideline. I don't know if you remember in, what's the movie with Bill Murray where in Ghostbusters. In Ghostbusters, Dan Aykroyd asked Bill Murray, well, how do you know that's the right way to get rid of the ghosts? And he says, I just follow the guidelines. That's right. Ghostbusters 1. Yeah. So, in summary, lifestyle modification has a large place in management. Weight loss, sodium restriction, the DASH diet, exercise, potassium replacement, moderation of alcohol, certainly can add many millimeters of mercury reduction. We talked about that yesterday, and it's always indicated either alone, okay, as a class 1 recommendation for those with elevated blood pressure or stage 1 hypertension, like our patient, with a low 10-year ASCVD risk, and in all those requiring antihypertensive drug therapy. Clearly, if you told him he had a 36% lifetime risk of developing ASCVD versus a 3.7 or 7% risk over the next 10 years, I think it'd be a little more impactful about the lifetime risk in this particular situation. So I wanted to just review lifestyle, and drug in this case. So, remember what we said. Overall, we believe the prevalence of hypertension will go from about 34% to 46% with the new lowering of the threshold to less than 130 over less than 80, or greater than or equal to 130 over 80 for hypertension. And we talked about the importance of lifestyle, but we said that in men and women 45 and less, the use of drug therapy would only be about 2% increased. And most of the drug therapy would be for older people with higher risk. Our patient didn't fall into that. That's why you need the risk calculator. So, comments or questions? Yes. Let's get the box because there are people on the web.
In this patient, of course, you don't really know what his lipids were before he was started on a statin.
Right, and in the calculator, even though they ask, is the patient on a statin, They take that into consideration of what the risk is. Basically, it's based on the lipids. So you're correct in that. So we didn't know what his baseline was, and that would be possibly a consideration for continuing his statin.
Yeah, I guess you'd have to decide if he wasn't on a statin and he had elevated lipids, which would change his risk more, the blood pressure or the statin at times, like if his HDL was quite high.
Yes.
I mean, LDL was quite high.
Let me just say, it is very unusual for me in my practice to ever stop a statin in an asymptomatic patient who is at risk when someone else has made that decision.
Okay.
Very unusual for me to do that. But shared decision making, more conversation with the patient might take some consideration into that decision. But it's very unusual for me to stop a statin in an asymptomatic individual who's tolerating the statin. Okay, we're going to move on. Good. Second case. 82-year-old black female recently relocated to a nursing home in your area and comes to your office to establish care. She has a past history of hypertension, early cognitive decline, but doing pretty well, minimal osteoarthritis, but otherwise her past history is unremarkable. She has not been on any special lifestyle modification. She has not been on antihypertensive medications for 6 months and is not aware of out-of-office blood pressures or in the nursing home. She has a strong family history of hypertension, but both parents lived into their 90s. She's thin, of ideal body weight. Her office blood pressure today is 142/92, an average of 3 readings, carefully taken. The nursing home corroborates similar pressures there as well. Do you have additional questions on this patient at this time? I'm going to give you some other data. Okay. Just based on this, and assuming that her exam is unremarkable and her lab values are unremarkable, what goal would you try to achieve in this 82-year-old? Less than 120 over less than 80, less than 130 over less than 80, less than 140 over less than 90, or less than 160 over less than 90? Or Dylan, if you could move it up just a little. Shared patient family member provided informed decision as to the best blood pressure goal. So what would you do for this 82-year-old woman in a nursing home that has been on antihypertensive therapy in the past and now has what looks like stage 2 hypertension, low stage 2 hypertension? And I thought that there'd be a lot of different opinions here, because this is a very, very complex decision. And I think that a number of answers here would be fine. Of note, I think E is the most common response, shared patient family member, shared decision making, and I think that may be the best answer, because I don't really think there's a right answer. But if you were going to go by a right answer, I think the right answer would probably be closest to less than 140 over less than 90, or perhaps less than 130 over less than 80. But let me go through this with you. I originally picked number 5 because I'm a little unclear on the best evidence base to use for this shared patient family member provider informed decision. But I do want to go through what the guideline says and go through a little bit of the evidence. So it's a 1A recommendation that treatment of hypertension in older people with a systolic blood pressure treatment goal of less than 130 is recommended for non-institutionalized, so she's in a nursing home, ambulatory community dwelling, she's not, 65 years of age and older with an average systolic of 130 or higher. Stage 1, current stage 1 guideline hypertension. That doesn't apply to her, but 2A does. It's a C recommendation of expert opinion. For adults 65 years of age and older with hypertension and a high burden of comorbidity and limited life expectancy, not sure about that, but clinical judgment, patient preference, and a team-based approach to assess risk-benefit is reasonable for decisions regarding intensity of blood pressure lowering and choice of antihypertensive drugs. I think this is an extremely important recommendation for all of us as clinicians, because it gives us the ability to make the best decision with the patient who you're seeing in the office. And good documentation in the chart will be extremely important as you make that decision with the patient. I do want to refer to the HIVET study because I think it's a seminal study and it's one of the best older patient studies that really applies to our patient in some ways. And this was a European, worldwide, not United States study, hypertension in the very elderly trial, asking the question, is there a benefit in treating hypertension in people age 80 years of age and older with a goal blood pressure of less than 150 over less than 80? In a previous pilot program, they were not able to show a benefit, and there was concern for blood pressure lowering in people with blood pressures above 150 over 80. But in this particular study, almost 4,000 patients with an average age of 84 with systolic blood pressures of 160 to 199, and when the trial was done, diastolics no higher than 110, or less than 110, randomized to an ACE inhibitor, often used in Europe, perindoprel, with or without a diuretic, indapamide, or placebo, double-blind randomized, one drug with or without the addition compared to placebo, to get to a target treatment of less than or equal to 150. This trial was monitored by a data monitoring safety board, and it was stopped early because the people that were not given active drug therapy with a mean age of 84 died sooner. Their total mortality was increased. In terms of the achieved blood pressures, in the placebo group, it was 158, and in the active treatment group, it was 143. This is one of the trials that's often used to recommend, in the oldest of the old, a systolic target of less than 150. And I told you that yesterday when I talked to you about what the ACP and the AAFP recommended in the 60 year of age and older patient. This 15 millimeter difference in mercury by office-detected blood pressure was great enough to show a significant benefit on multiple endpoints. When you look at the demographics of the trial, the mean age was 84. Their baseline blood pressures was 173 over about 91. 1/3 of them had isolated systolic hypertension. Remember, their diastolic had to be less than 110. But certainly it could have been less than 90, and they could have, at the time of the trial, had isolated systolic hypertension, which was greater 140 or greater and less than 90 at the time of the trial. Interestingly, only about 12% had underlying cardiovascular disease, and they were what looked like a very healthy group of patients. When you compared the blood pressure reduction with perindoprel, with or without a diuretic, versus placebo, you can see the blood pressure differences, and this is a difference of about 86 to 82. And you can see the forest plot here. I already told you about total death. Stroke, it was stopped early. Stroke was going in the right direction. Stroke death was significant. All-cause death was significant, less likely to die with active drug, the reason for stopping the trial. But everything, and once again, look at heart failure, how robust heart failure prevention, clinical heart failure prevention is with a difference of 158 to 143 mean. So everything was going in the right direction, and this, I think, gives us good comfort in knowing that when you take these elderly folks that we see, and they have blood pressures of 170 or greater, and we're bringing them down to less than 150, we are doing them good. I think it's an important point. Now, in addition to lifestyle modification, would you use antihypertensive therapy on this woman? And the answer is yes or no, and you can answer now if you're answering. Her blood pressure currently is 142, and you've only seen her one time. And you might want to get more blood pressures. Maybe you don't need them. A lot of decisions. A lot of decisions. Okay. Now, in addition to lifestyle, would you use antihypertensive drug therapy on this patient? I'm not sure. I know from HiVet that she's going to do better at less than 150. She's at 142. I've only seen her one time. I can see her back. I can get the nursing home to call the office and get more blood pressures. But I could understand why you wanted to use drug therapy, if that was what you thought, because she had been on it in the past. But I wouldn't go that way. Now, I just want to re-emphasize the SPRINT trial, because that has driven a lot of the older recommendations that we've recently been seeing that's different from the ACP and the AAFP. Remember, these folks were at least 50 years of age, well represented with African Americans. We don't usually get a large percentage of African Americans in our clinical trials, which we would like to see more of. We'd like to see more women in our trials, without a doubt. And depending on the blood pressure, they could be on 0 or 1 medication, but if they were closer to either 140 or less than 120, we would be more likely to allow them to be on up to 4 medications. And we looked at one of 4 specific groups, I'll go back, and that's the presence of clinical or subclinical cardiovascular disease. They made up 20%. And then we had chronic kidney disease. They made up 28%. A Framingham risk score. Let me see if I can get this thing. Well, the pointer's not working too good. And the overall mean Framingham risk score was actually 20%, okay, in both groups. In all patients, or they were 75 years of age, and 28% of the total population were 75 years of age and older. Now, these were the exclusion criteria. There was an ongoing trial with stroke and blood pressure, so they were excluded, any past history of a stroke. We had already looked at diabetics in the ACCORD trial. We talked about that yesterday. We didn't want to enroll people with heart failure and deny them some of the strategies that improve their outcome while we were controlling blood pressure. We didn't want heavy proteinuria in the trial. We didn't want people that were closer to transplantation or dialysis, so they couldn't have a GFR less than 20. They could never have any problem with taking their medications for any disease state. Adherence, reviewed in the chart. They had to be ambulatory and had to be able to walk into our clinics, and they could not be living in a nursing home. Our patients living in a nursing home. So this patient really wouldn't qualify for SPRINT. You do know that we got less than 140, 136, less than 120. We achieved 121.4. It took one more class of medication, and I wanted to show you the paper, which I didn't show you yesterday, which specifically looked at 75 years of age and older patients, okay? The older of the old within SPRINT. And once again, the older patients that were targeted to a less than 120 lived longer, significantly, when the trial was stopped early, than the standard group, less than 140. And the same was seen for the 5 composite endpoints of the primary outcome, driven by heart failure. And very importantly, when we looked at frailty in this paper, published in JAMA, and can you move it up just a little, because all the references are on the slides. I just want to, you can see it's JAMA 2016. Jeff Williamson is the first author. I just want to show you that regardless of the frailty index used to stratify the patients by their baseline characteristics, independent of the frailty index, even the most frail still benefited from the lower target. And by the way, in the elderly subgroup, the achieved blood pressure was about 124, not 121. Okay. So the guideline gives us a rationale for less than 130 in older adults. Large numbers of older adults have enrolled in randomized blood pressure treatment trials, and the randomized trials have shown blood pressure lowering to decrease CVD morbidity, mortality, and does not increase the risk for falls or orthostatic hypotension. That's from the guideline. Let me show you SPRINT specifically. Okay, so first I want to show you that in SPRINT, if you were in the intensive less than 120 target versus the standard target, and if I can get this to work, you are more likely to be hyponatremic with a sodium less than 130 and a potassium less than 3, hyponatremic, okay? And the difference is about 1.7 per 100 for sodium and 8 per 1,000 for potassium. Now remember, this is interesting because you were not more likely to be hyperkalemic, and many of the patients were treated with chlorthalidone, a RAS blocker, a CCB, 3 drugs, and some were on spironolactone. So we didn't see more hyperkalemia in the intensive group, but we saw more hyponatremia and more hypokalemia. So clearly you've got to look at the metabolic profile more. You have to look at the metabolic profile and be more surveillant, if you will, than just to allow the patient not to be seen for 3 to 6 months. And just look at the orthostatic hypotension. You can see that for orthostatic hypotension, it was less likely in the intensive group, significantly less likely, and the difference was about 1.7 per 100 in the standard group. Okay. But these are the subgroups from the guideline of older adults for which an individualized approach to blood pressure targets are utilized, should be utilized. For patients with recurrent falls, non-ambulatory, dementia including Alzheimer's disease, high burden of comorbidity, neurogenic orthostatic hypotension, as in Parkinson's disease, nursing home residents, or patients with a limited life expectancy. So the guideline spells out for you situations where you and the patient and or their family have to make these informed decisions. So when you go from a very high blood pressure, let's say 170 or greater, to a blood pressure of less than 150, with antihypertensive therapy, you are making a significant impact on their outcome and improving their outcome. We have been able to show that in patients who come into the trial on up to 4 medicines with a mean blood pressure of 140, and we reduce it to 121, or if they're 75 years of age and older, to 124, compared to about 136, they do continue to benefit as well. But remember, there is an incremental benefit as you lower blood pressure, and you have to decide what is the best target for these patients based on their comorbidities. So, in summary, the 2017 ACC/AHA guideline uses lower systolic treatment goals for older adults, less than 130. The goal is for ambulatory, older, sprint-like adults, often seen in office-based practices. Between 6 and 9 million U.S. adults over age 75 may benefit from this new target within the new guideline. I want to show you this because I didn't show it to you yesterday. This is the Kaiser Permanente algorithm before the new guideline came out, when the goal for blood pressure reduction was less than 140 over less than 90. And I want to show you that they do use lisinopril HCTZ as one of their initial strategies if the patient can be put on an ACE inhibitor, and they up-titrate to 20/25 BID. And they do that because they want to get up to 50 milligrams of hydrochlorothiazide when blood pressure is not at target, and because of its shorter half-life, they want to use it twice a day. If the patient is ACE intolerant or pregnant potential and you don't want to use a RAS blocker, they recommend chlorthalidone or hydrochlorothiazide. Notice that it's half the dose compared to 25 to 50 of hydrochlorothiazide. If they're not controlled, they add a CCB. I always say a little CCB is better than no CCB, but I do like 10 more than 5 than 2.5, depending on the side effect profile. The good thing about amlodipine, and the reason why, if you had to put it in the water of a third world country and lower their whole blood pressure threshold, is because it needs no metabolic or renal functional follow-up. And so the only thing that often happens is patients could develop peripheral edema, but that's something they would complain about. Okay? Very safe, very effective blood pressure driver, blood pressure lowering agent. And then if not controlled, they say you can add atenolol, I know, or you can add spironolactone, or increase the dose. If on a thiazide and the estimated GFR is 60 or greater, we say 45 or greater, and the K is less than 4.5. I just wanted you to see this algorithm. And by the way, they now are up to 90% control of less than 140 over less than 90. They're redoing all the data on 130 over 80. Okay. In our patient, 82-year-old female in the nursing home, in addition to lifestyle modification, if you were to treat her blood pressure with drug therapy, what would you treat her with? And let's go to the answers. It's a beta blocker, thiazide-like diuretic, an ACE inhibitor or an ARB, a CCB, or either 2 or 4. If you were going to use drug therapy for her, and you agreed that you were going to lower her blood pressure less than 140 over less than 90, perhaps less than 130 over less than 80. I wanted to go over this too. Okay, and the most common answer is E, although it's pretty close. And I thought E was the best answer also. And I want to get to the guideline. Remember, the guideline says Class 1A from systematic review for initiation of antihypertensive drug therapy. First-line agents include thiazide diuretics, CCBs, and ACEs or ARBs. However, in black adults with hypertension but without heart failure or chronic kidney disease, that would be our patient, including those with diabetes, initial antihypertensive treatment should include a thiazide-type diuretic or CCB. So I just want to re-emphasize the fact that when we have a choice of 3 initial classes of drugs when there's no compelling indication, blood pressure reduction is greater in the oldest of the old and in the African American hypertensive with a diuretic or a CCB. These 3 classes of drugs, though, work extremely well together. Beta blockers should be included in the regimen if there's a compelling indication for the beta blocker. HFrEF or post-MI are the 2 big ones. Heart failure with reduced EF or being post-MI. And being post-MI is usually within the first 2 years to up to 3 years. The evidence for lifelong beta blocker therapy after you've had an MI for structural remodeling and the benefits of the beta blocker dissipates over time. So it's questionable if you should continue the beta blocker for the lifetime. You decide to treat the patient with medication. You add HCTZ. The patient returns to the clinic in 1 month later, and the blood pressure is properly taken, and it's now down to 134 over 86. What would you do next? So let's say you wanted to get the blood pressure less than 130 over less than 80. Would you increase the HCTZ to 25? Would you switch to lisinopril 10, 12.5? Would you add amlodipine? Would you switch to benazepril 20, amlodipine 5, or do nothing as blood pressure is well enough controlled? And this is a very, very controversial question, and let's see what the group says. Okay, this is interesting. So some folks are going to add a CCB. It is highly unusual to find a patient with their first 2 drugs ever, a thiazide diuretic and a dihydropyridine calcium channel blocker. And there haven't been clinical trials that have, there's been one, but not many clinical trials that have looked at these 2 drugs as the first 2 drugs. I think most people would answer A, but I just want to leave you with one sort of pearl of antihypertensive therapy. I think you could increase the HCTZ to 25. I think many would do that. I think others might switch to lisinopril HCTZ, as in the algorithm that Kaiser likes to use. And I think some would say do nothing as blood pressure is well enough controlled. But I just want to show you that when you add another drug from another class, if it's a thiazide or a beta blocker or an ACE inhibitor or a calcium blocker, to another first-line agent, by adding the lowest dose titration of the new class to the initial dose titration, you'll always get much more blood pressure reduction than when you double the dose of the same antihypertensive. Okay. And they really emphasize in this guideline the use of 2 drugs initially when it's stage 2 hypertension, 140/90 or greater. And this really suggests that you get more blood pressure reduction, but the real issue is when you go to full dose, you get more side effects. So by adding another drug from another class, you ameliorate the side effects and get more blood pressure reduction. Okay. So although we know the results of SPRINT, our patient would not have qualified for the SPRINT study as she lives in a nursing home. Older patients with comorbidities living in a nursing home are more prone to hypotension. She remained on HCTZ and her blood pressure continued to be well controlled with the agreed upon shared decision with a family member of a goal of less than 140 over less than 90. She's feeling well. Her BUNK, sodium, and orthostatic pressures are all okay. Okay. Questions or comments on this case? Yes, we'll get the microphone over to you.
What about indapamide versus chlorthalidone? I notice you're a big fan of chlorthalidone, but I use a lot of indapamide over the years. And
I think indapamide's an excellent evidence-based thiazide-like diuretic, long-acting. I just think that we would like to see more people using chlorthalidone, because that's been used in most of the studies, in the NIH studies that we've done.
It has a long half-life.
Very long
similar
half-life.
to chlorthalidone.
Yes, yes. I don't have any problem with that. And it's an evidence-based thiazide-like diuretic, including in the HIVET trial as an additive strategy. It doesn't have as much first-line evidence as chlorthalidone. First-line evidence. And that's why we recommend chlorthalidone. Okay, we're going to move on. Third case. 58-year-old black male comes to the hypertension clinic with a long history of poorly controlled hypertension for further evaluation of resistant hypertension. At today's visit, his blood pressure is 148/98, taken appropriately, and a review of his home monitoring suggests poorly controlled blood pressure. He actively exercises, has lowered his salt intake, and rarely drinks any alcohol, beer, or wine. He has not smoked in the past 15 years, but was a significant smoker in the past. His review of symptoms is negative for headaches, palpitations, excess perspiration, cardiac or pulmonary symptoms, and he's never been told that he snores, and he denies daytime hypersleepiness. Physical exam and labs, including his potassium, were normal, as was his estimated GFR, but his EKG showed LVH by voltage. A past echo found in his EMR showed concentric LVH done for a heart murmur, which turned out to be a flow murmur. I don't know why I have problems. He's currently adherent on valsartan 320, amlodipine 10, and HCTZ, and he takes his valsartan and amlodipine at bedtime. So, let's go to the first question. Well, Does the patient have resistant hypertension? Yes, no, I am not sure. Boy, you guys are quick. Very good. Okay, there are only 8 people, 9 people answering, and okay, we'll move on. The answer is yes. We talked about this yesterday. And this is the 2008 scientific statement. And we went through this yesterday when it was 140/90 as the target on a 3-drug regimen, including a diuretic, with all drugs prescribed at near maximum or maximum recommended doses, so we didn't suffer from clinical inertia. The 2008 scientific statement added the term controlled resistant hypertension when you're on 4 or more medications in an effort to try to minimize that 4th medication if you could do other things to get the blood pressure more effectively controlled, like more lifestyle, etc. This is from the new document. The reference is on the slide, but it just doesn't show. And now we've moved the target of 130/80, which is the definition of hypertension. And we also have controlled resistant hypertension. We're going to have a new guideline coming out in a couple of months on resistant hypertension. What will happen to the prevalence of resistant hypertension as we lower the blood pressure down to 130/80 or greater? It'll go up, estimated from a paper with the reference down here, to 17%. What would you now do? Would you perform a 24-hour ABPM after administering his blood pressure medicines first thing in the AM to rule out white coat hypertension? Would you perform a CT scan to rule out an aldosteronoma? Would you draw plasma metanephrines, norepinephrines? Would you order a sleep study, or would you refer the patient to a hypertension specialist? And I think the best answer is what most of you are suggesting, and that's perform a 24-hour ABPM. Now, remember that the guideline is concerned about the availability that you have to getting a 24-hour ABPM. So in the guideline, they write, you should exclude pseudo-resistance, ensure accurate office blood pressure measurements, assess for non-adherence to prescribed medication regimens, we've done that, and obtain home, work, or ambulatory blood pressure readings to exclude a white coat effect. I do want to just define masked and white coat hypertension in this little diagram I've drawn. Now we have the target of 130/80. So when the systolic is greater than 130 or the diastolic is greater than 80, when they're both, or when one is elevated, they're truly hypertensive, multiple readings at a given visit on 2 or more opportunities to get blood pressures, 2 or more different opportunities, usually separated by at least a week apart. If they're both lower, if they're consistently lower than less than 130 over less than 80, they're truly normotensive. The white coat, of course, is in-office high and out-of-office low, okay? In-office high and out-of-office low. And the masked is in-office low and out-of-office high, or at least greater than 120, which is normal. The United States Public Service Task Force has always recommended that we screen people 18 years of age and older for hypertension. But what they said in 2015 was to use office blood pressure as a screening test, but to confirm the diagnosis with out-of-office blood pressure readings prior to the initiation of antihypertensive therapy. And ABPM is the reference standard. The guideline did not feel that ABPM would be available to most clinicians, and so they recommended home blood pressure monitoring when ABPM is not available. This is all in your updated slide set that we now have on the web. I want to show you that we're not the only ones that have been saying this, because the Canadian Hypertension, the CHEP program, have been recommending ABPM. The British, since 2011, in the National Institute of Clinical Excellence, has been recommending ABPM to confirm these types of patients, and the European Society of Hypertension. So out-of-office blood pressure confirmation of in-office elevation is imperative to rule out white coat. Somebody asked yesterday about ABPM. I wanted to talk a little bit about it. We get multiple readings, usually every 15 to 20 minutes while awake and every 30 minutes while asleep. It's an ambulatory Holter monitor, if you will, of blood pressure. The evidence suggests it's superior to office blood pressure in predicting outcomes, and it's considered to be the non-invasive gold standard. These are the new cutoffs with the 130/80 definition of hypertension. This will all be in this handout. Awake, daytime blood pressure, 130/80. Nighttime sleep, 110/65. 24 average, 125/75. This is the kind of printout you get with an ABPM that will tell you the daytime blood pressure on the far left, the nighttime blood pressure and the dip, and then if there's a morning surge in blood pressure. This is back when we were using 140/90 as the accepted definition of hypertension. Okay? And I just wanted to show you the new recommendations, and this is in the document, but it's hidden. The new recommendations for hypertension and stage 2 hypertension, okay, and normal blood pressures on the top, okay? So this is an important slide if you're interested in ABPM. The ABPM should have at least 40 readings that the clinician, the physician clinician or clinician can interpret. The awake blood pressure, the sleep blood pressure, and the dipping, the percentage of blood pressure reductions at night, and the threshold. Usually we accept 35 to 40% of the blood pressures in these 3 different periods that are above what the normal is for the ABPM. So we're going to look at resistant hypertension. We've talked about this a little bit, and I'm going to just try to get through it. We've ruled out pseudo-resistance. We've talked about true resistance and all the things you go through. We've talked about the new screening test, the controversy of how to rule out a FeO, either with a blood test or a 24-hour urine. We've talked about renal vascular hypertension and renal artery stenosis, and sleep apnea, and the fact that we don't really believe that even when it's recognized, as important as it is, that we can really effectively reduce blood pressure all that much with effective CPAP, although the recognition of sleep apnea and the use of CPAP is extremely important. In addition to a low-salt diet, what would you do next to this patient on 3 medications? Would you add carvedilol? Would you change the HCTZ to chlorthalidone? Would you add DILT? Would you add an ACE inhibitor? Or would you refer the patient at this point? And okay, very few answers, but in my practice, I would have changed the HCTZ to chlorthalidone at the same dose. We've talked about chlorthalidone. I wanted to show you this one study that I don't think I showed you yesterday. This was a head-to-head comparison of double-blind, small study, randomized of 25 of chlorthalidone to 50 of hydrochlorothiazide once a day, taken in the morning. And you can see that you're always getting more blood pressure reduction with 25 of chlorthalidone than 50 of hydrochlorothiazide. However, the nighttime blood pressure is significantly reduced more with chlorthalidone than hydrochlorothiazide, that long half-life. We've seen that by switching. We've seen this, and we've seen this, the efficacy of chlorthalidone. And we know that it has a longer half-life, a greater potency, at least 1.5 to maybe up to 2 times as potent on a milligram per milligram basis as hydrochlorothiazide. He returns tolerating the 25 of chlorthalidone with a blood pressure of 138/92. What would you now add? Carvedilol, a clonidine patch, diltiazem, spironolactone, or terazacin? And the best answer is spironolactone, in my opinion. I think carvedilol is also an optional choice here, but I like utilizing spironolactone, and that's what I picked at 12.5. And we saw the Pathway 2 study comparing spironolactone in blue to bisoprolol, left to right, to doxazosin, and to a placebo. And we've seen this, the recommended approach to hard-to-control hypertension, okay? This is also taken from the new guideline. Although renal artery stenosis and other secondary causes of hypertension were considered, medical management was pursued, and no further studies or lab tests were done at this time. Spiro was started. He was seen monthly. After 2 months of normal potassium, sodium, and renal function, Spiro was increased to 25. Blood pressure decreased to an average of 128/84 for another month, and the patient continued to do well on follow-up. And that patient should be seen every 3 to 6 months. Questions or comments? So a patient with lifestyle modification, a patient with shared decision-making and difficult decisions to make based on the new guidelines, and a patient with resistant hypertension.